Good morning, everyone. Thank you for joining us today. If you're wondering if you're in the right place, today we are hosting the Crisis Assessment Part 2 for the Medi-Cal Mobile Crisis Services benefit. This is a supplemental training, so optional. We appreciate you being here. Today we're going to cover the actual standardized crisis assessment tool that was released by the state. We're going to go over each section as well as some of the prompts from the companion guide that was also released with the assessment tool. Just a quick disclaimer, this presentation was prepared for the Medi-Cal Mobile Crisis Training and Technical Assistance Center, also known as the MTAC project, which is funded by the California Department of Healthcare Services and administered by the Center for Applied Research Solutions. All of the material in this presentation, except that taken from copyrighted sources, is in the public domain and may be reproduced or copied without permission from DHCS or the authors. Citation of the source is appreciated. Please do not reproduce or distribute this presentation for a fee without specific written authorization from the MTAC team or project. I will do a quick introduction. So my name is Danielle Ragib. I'm a licensed clinical social worker here in the state of California. I'm a training and technical assistance specialist with the Center for Applied Research Solutions, and I am working on this project. Many of you have interacted with me or seen me before in many of the trainings, and I will let David introduce himself.
Yeah, good morning, everyone. Thank you. David Lopez, also with the CARS, the Center for Applied Research Solutions. Looking forward to just get going over the tool today. And yeah, so back to Denny.
Thank you. This is from the Medi-Cal Mobile Crisis Services benefit, the BEN 23025. Just talks quickly about mobile crisis services. You know, the intention is to provide rapid response to individuals experiencing a behavioral health crisis in the community, and really with the goal to provide them relief, de-escalation, and stabilization techniques to be able to stay safely in the community. With this benefit, there is this hope for a transformation of care in crisis services in California, really hoping to make mobile crisis services more resolution focused and really working towards providing people relief in the community while using the least restrictive means necessary. Mobile crisis services should be person-centered, trauma-informed, equity-driven, really be focused on that brief intervention. So working towards, resolution, resolving the crisis in the field. And then again, navigating away from, unnecessary law enforcement involvement or inpatient psychiatric hospitalization. So really working towards a lens of least restrictive interventions. And as always, the mobile crisis services should be culturally responsive, linguistically appropriate, and accessible for all. These are our learning objectives for today. By attending this training, participants will be able to understand the BEN 23025 requirements for crisis assessment. Also, you will learn the components of the standardized Medi-Cal Mobile Crisis Services crisis assessment tool, including screening, consultation, and the disposition of mobile crisis encounters. Hopefully, you'll gain some confidence in using the tool. And then we also want to clarify some role specifications for completion of crisis assessments. There's been a lot of questions about that, so we just want to provide some clarity there. And at least 4 ways to engage in crisis assessment using trauma-informed care and a culturally responsive lens. Those of you probably already know that there was a crisis assessment part 1, and that was a required training. You can find that training on our website. The link is here, and we'll also put it in the chat. And I'm going to hand this to David because this is where David talks about his training.
Yeah, so on that one, what we focused on was just kind of going over that client-centered approach and looking to see how we can best assess the individual in a compassionate and caring regard, meeting the people where they're at and understanding that they are the experts in their own life. Even as we go through this tool, really building that rapport, joining with the client and meeting them where they're at is essential in anything that we do in crisis assessment. Establishing that relationship and coming through, meeting them where they're at in their journey, and then helping them to provide a resolution-focused interaction. The goal of the mobile crisis benefit as a whole is to, when you encounter someone that's in a crisis, is to really try to de-escalate the individuals in crisis, meet them where they're at, work on what they can do, give them a sense of control, a sense of autonomy, and then potentially help them resolve that crisis, or at least alleviate some of that psychological pain in real time, with the hope and intention that they can stay in their environment, like they don't have to go to hospitalization. Of course, we understand that there are times when a further level of care may be needed and warranted. But the benefit and everything that's been done around this benefit is to help the clients least invasive way, to give them some strategies to help them to unpack some things, mitigate that crisis and hopefully be able to stay safe in the.
Just to go over a little bit of the BEN guidance around crisis assessment. And just to recap kind of what David said, like historically, when we would go out for a mobile crisis response, we're really evaluating just for suicidality or homicidality, really those three criteria that we look for when we're putting someone on a hold, right? But now we're shifting more towards like, let's provide intervention, something that can be brief, but also provide relief, and working towards keeping that person in the community, and really deliver a transformed service that does not strip civil liberties, but provides relief. Creating trust so that individuals in crisis will seek support and talk about crises or suicide openly without fear of being institutionalized against their will. And so that's really what the transformation has been about and the main focus. The BEN does talk about the initial face-to-face crisis assessment. So mobile crisis teams shall provide a brief face-to-face crisis assessment to evaluate the current status of the member experiencing the behavioral health crisis, again, with the goal of mitigating any immediate risk of danger or to self or others, and really focus on determining a short-term strategy for restoring stability and identifying follow-up care as appropriate. Again, with the initial face-to-face crisis assessment, at least one on-site mobile crisis team member shall be able to conduct a crisis assessment. Then this part is really important. Any qualified team member who has completed the crisis assessment training can complete the crisis assessment. There's been a lot of confusion on who can complete the crisis assessment. It's not just the clinician. If you have a 2-person team going out and they're both peers and they have both been trained in the crisis assessment, then they can complete the crisis assessment. And so it's really anyone from that list, table 1 in the BEN, that is considered a qualified team member. As long as you're trained in crisis assessment, you can complete the actual assessment. That includes peers, community health workers, first responders, an SUD counselor, licensed and waivered clinicians, so anyone from that list. And again, it's on table 1 in the BEN. It is best practice really to determine who is the most appropriate person to initiate the crisis assessment. You get a call, it comes through dispatch, it gets triage, you get some information from dispatch around what's happening, what's the crisis event. And it's okay for the teams to kind of huddle and figure out, oh, you know what, you've got some lived experience with this type of crisis, maybe you should take the lead. And really having those conversations before getting to the crisis. And that may shift when you get there, because sometimes we get information and then when we get there, it's completely different. And that's okay. It's being adaptable, working as a team together. Every situation is different, and it's important to be able to adapt to the needs of the person in crisis when you're out in the field. That's what makes crisis work so unique and different, but also challenging and hard. And so it's important to take that into consideration when you're trying to really determine who's the best fit from the team to be able to do this today. Consistent with the SAMHSA national guidelines for behavioral health crisis care, the crisis assessment tool that was developed by DHCS, and also if your county is choosing to develop your own and use your own, it should really include the information below. So either from the person in crisis or their significant supports or any collaterals that might be available to you when you're out in the field. So causes leading up to the crisis, so including any psychiatric, social, familial, legal factors and substance use, safety and risk for the member and others involved, including an explicit assessment of suicide risk and access to any weapons or firearms, strengths and resources of the person experiencing the crisis, as well as those of family members and other natural supports that might be available, recent and inpatient hospitalizations and or any current relationship with a mental health provider, any medications that are prescribed for them, and are they using the medications? Are they using them appropriately? And then again, a rapid determination as to whether the crisis requires coordination with emergency medical services or law enforcement, and then really looking at medical history as it relates to the crisis. And so these are the key components that should be a part of any crisis assessment tool under this benefit. Again, the focus is to deliver person-centered relief and support to the member in their community or location of their choosing. And so crisis assessment using a trauma-informed and culturally responsive lens. This is just a revisit from the crisis assessment part 1, which David delivered beautifully, and really looked at, how does trauma impact people in crisis? How does it show up in crisis? And it can make it challenging for individuals to be able to verbalize and express in a healthy way, what they're feeling and thinking when they're in a crisis state. And so being able to, one, have awareness and knowledge of that when you're going out and responding to a crisis is helpful because, we may get nonverbal responses to questions that are asked. We may see other symptoms and signs it's information for us, right? Behavior is information. And what do we do with that information? We want to make sure we build our awareness of any nuances that can come up when we're responding, to culturally diverse communities. In Native American communities, silence is innovative or it's normative. Eye contact can be seen as aggressive. So how do we make sure that we are we have cultural humility, which is an ongoing process. It doesn't end. It's not a competence check mark or a checkbox. And so understanding their support systems, what has happened to them before and during the crisis is really important. We want to make sure that we always ask open-ended questions instead of leading questions, which you will see in the actual tool itself and in the companion guide that came out with the tool. An example of an open-ended question is, how would you describe what happened to you? That leaves it open to them to give us any response, right? Versus, what has happened to you makes you feel like you can't go on, doesn't it? It's kind of like a yes or no. It's also very leading. We're not giving them the opportunity to say what they really think and feel. It's important to pay attention to your intuition and consult with others as needed. So you have a team, bi-directional consultation between clinicians and peers or community health workers is important. Clinicians can learn from peers, people with lived experience. They can provide guidance on how, to work with someone, how to relate and connect, and vice versa. And so it's important to understand that everyone on the team is just as important and brings some sort of unique perspective and experience. And so it's important to also watch your nonverbals. So when you're listening, do not communicate agreement when you are not intending to. So sometimes we may shake our head in agreement when we're listening to someone, right? Therapists do that a lot, right? We do the nod and the head shaking, but it doesn't mean we're necessarily agreeing with them. We're just trying to show that we're listening, right? But there are other ways to do that. We can summarize, we can rephrase, we can say, this is what I heard. Help me, understand more, and always approach each situation with wonder and curiosity. And discussing response fatigue and how to pace a crisis assessment to get the best outcome is very important too. So these are all things that you can do as a team to discuss together prior to going out. And one more thing that I really want to highlight is when it's appropriate, the person with lived experience may be the best person to initiate the crisis assessment, to share strengths and challenges and experiences. And again, determining who will lead the crisis assessment is a case-by-case scenario, and it should always be happening. That should be something that you're always discussing and planning for as a team when you're going out to the field.
Thank you, Danielle. And so now we're going to start to go over the actual tool itself that was standardized by DHCS and the communities. We're going to spend some time on each of those sections and kind of just break down what is in each section. Again, provide those prompt sets in that companion guide and give you an overview of how it can be utilized in the field. As Danielle mentioned, this is a tool, and any crisis assessment tool is as good as you need it, right? You want to make sure that you're engaging in conversation and you're going through and gathering information throughout the assessment while being very client-centered and meeting them where they're at. The last thing people want is when you come out and you pull out a flip chart or you pull out your assessment and you're kind of just going along with them. That makes it feel more interrogation, and this is really conversation. So just be mindful of that when you're going out there. Also to note that if your county is using a tool that's different than the standardized tools, each tool can be expanded upon to better fit the needs of your community. However, no items could be removed. Some counties have opted to develop and use their own standardized tools that have been or are their best practice and are being approved by DHCS. So if it has been submitted with your implementation plan, DHCS will review them and then provide that approval once they review it. Okay, so starting off with the first section. This is the first section of the actual crisis assessment template. Now, this piece focuses on information that may or may not have been gathered during that initial triage or dispatch. Some counties may be integrating that dispatch tool into their EHRs, and we're getting wind or potentially this will be introduced into different EHRs that's hosted through counties. Smart Care is looking at integrating it into the systems right now. But so the first part, it's going over some of the essentials. You're looking at what's the individual's name, what's the date of service, the mobile crisis teams, the dispatch time. That's important. So you know how long it's taking you to get there, your arrival time, and the actual duration of the call itself. Again, gathering that individual's name, you want to get their date of birth, the team members who are responding to the actual call, the service location, where the call is going to be taken at or where that service is going to be provided. It can, because you're responding out in the community, potentially it's at a storefront, it could be at a school, it could be at the individual's house, however it may be. So get down that information there. And then the individual or the reporting party phone number, who is asking for it. And one of the first things we want to do is, more honestly, is making sure that the person in crisis does not need any medical attention. When you get on scene and once you evaluate that, taking your time and meeting the individual, you want to make sure that there isn't any pressing medical concerns that need to be elevated and taken care of prior to going through that crisis. Let's go forward to the next. Now here in this section, we're looking at the crisis event description. And as Daniel mentioned, we want to ask them what's going on. We want to start to gather their story and hear it in their own words. Here we want to pay attention to their body language. We want to get a feel for what's been happening. We want to give them an opportunity to share their story. And we want to hear everything that we can from them. So can you tell me a little bit more about what's going on? What has happened to you? Can you tell me a little bit about how, whatever they may say has changed or affected you? And who else is concerned about this and is trying to support you? Are they reachable? These are some listing here that are in the actual prompt bag. And it just having that open-ended conversation, building that rapport and hearing their story. Once you start asking it, you're going to be able to gather more of that information and start to move on to the next section of it. So here we're looking at causes leading up to the crisis event prompts. So causes leading up to the crisis event, and there could be a lot of different things that's happening in that individual's life. We have to be mindful that we're meeting them in a slice of time, right? And then this point in time when we meet them, they've been living their whole life with a lot of different interactions, a lot of different social inputs, familial makeups. And so we want to go ahead and start getting that information from them. We want to look for if there are any psychiatric concerns, other cultural considerations, social, familial, legal factors, or substance use. And when important, we want to collect collateral information when available from other people that may be on site. That could be good good reporters or good historians, or gather additional information. Strong strategies we've heard with the 2-person teams is that individuals would go out. One team member would potentially meet with the person in crisis, and another one of the team members would go forward and look to gather some of that collateral information from family members, from teachers, from supports, whatever or whoever may be around that's appropriate that can provide additional information from that individual. Some questions here that you want to start looking at is, Are there any relationships with your family or friends that are contributing to how you're feeling today? Are there any stressors that's going on? Have you been diagnosed by a doctor or another provider with any mental health conditions? If so, which ones? Some ways that so when we look at adaptations, and I want to explain this, in the guide itself, we have different adaptations of how you can ask these types of prompts. And feel free, you can use that as you wish and whatever's most appropriate or culturally appropriate for the individual in crisis. So one adaptation would be, are there challenges with your emotions or thoughts that you have talked to someone about with someone who helps with healing? Now, this was written by one of our partners, Josh Severance, and this comes from a Native American language approach. But when I hear that, that could be applied to so many different cultures. Another thing to assess is, are you experiencing any sleep disturbances or change in appetite? That's a standard question. And an adaptation with that would be, have you been sleeping? How have you been, as you're sleeping and eating bed? Are they in harmony with you, and how do you usually feel? Another prompt would be, have you recently experienced any major life changes or losses? Another adaptation to that could be dependent on the individual. Have there been changes or losses in your life that are affecting your heart or spirit? Have you felt hopeless or overwhelmed recently? Another way is, can you share how often the blow feels too heavy or out of reach? And each one of these adaptations here is listed to give you a different tool set when you're working with a multitude of cultures. As we know, California is very diverse and everyone has a different background. So when we're meeting them, we want to use that plain language as best as possible to meet them where they're at and adapt it to the person in front of you who's in crisis. If when you're upon the scene and you arrive and the individual is escalated and they're emotionally dysregulated, you may want to spend a few minutes just helping them emotionally regulate. As Steve Fitch said during one of those the trauma-informed care training, we really have to allow that individual to regulate and give them space. And part of crisis response is that opportunity to meet them where they're at, join them, practice some emotional regulation, help them re-regulate, help them be in a better space. You can practice tactical empathy. You can model them. You can help mirror them. Even your tone and the way you speak can help slow the situation down. As you know, when people are in crisis, they can be elevated and be really energetic. They can have pressure in speech, and all those things are signs that they're still not in the best space to help them to help tell you what's going on. So joining them, meeting where they're at, giving them that space and opportunity and a voice to listen to, or you're allowing their voice to be heard. I want to ask for a check-in to see if there's any trauma that may be going on. And this is something where I kind of let into what you were saying. So if we're seeing that they're emotionally dysregulated or they're going through, this is something that we want to check in to see if that's a contributing factor to how they're presenting. For example, individuals that have suffered trauma, they can have flashbacks and they can have these types of fallbacks to they're in a bad state. And when they do that, they present very differently. That presentation, because it's a callback and they entered into a crisis. Some activity activated them and made them feel a little bit different. Now they reverted back to that space. With that, it can look or present very different if you're not assessing or trying to gather that information if they have been experiencing trauma. So part of that, you can ask them, did you have any fears as a child, teenager, or any more recent in your life, and how to cope with them? Are there any painful memories or there have been any challenges or losses in your life that are affecting your heart? And again, going back to that pacing piece during assessment, we want to be mindful of how we're going, how we're being in good space. We want to meet them where they're at, and we don't want to be too pressured for them. So pacing that assessment throughout is very important. And we want to make sure that they're okay. don't want to ask members to describe emotionally overwhelming traumatic events, is that can activate them or bring up some of those things during that crisis event, during the crisis assessment. So when we're out there, we want to make sure that we're gathering with them, meeting where they're at, helping them regulate, and that's the goal in crisis assessment. Danielle, do you have anything to add? But anything else you want to add to assessing for trauma, Danielle, or think with our audience today would like to know?
Yeah, I think what, kind of what we covered at the beginning in regards to how trauma shows up when someone's in crisis, and when we think about, responses and just the operation of the brain in those moments, they may not be the most rational or logical, and that's just anyone. If we're in a crisis and a certain part of our brain has been activated, we're more about survival in that moment. And so what can we do to help that person kind of feel more grounded and help their nervous system relax? And that might be just sitting down and taking a breath with them, or asking them if they need a glass of water, or, if it's a kiddo, like would their favorite stuffed animal help in the moment? Really that focus on helping them feel more grounded. And even when you're asking about trauma, you might see those responses, right? You might see the tension happening, or there might be some body movement happening that you notice, and being able to acknowledge that, like, I see your body reacting to this, and holding space for that, right? Helping them feel connected and heard is the most important thing, especially when we're asking specifically about trauma.
So the next section of it is assessing for psychosis or mania. And in that, we want to make sure that we're checking in to see if that individual in crisis is experiencing any types of these symptoms. Some things to ask in one of the initial prompts is, are there things that you are seeing or hearing that others may not be seeing or hearing? Are you feeling like you do not need to sleep? So the first one would be assessing for any type of psychosis. The mania would be going on along with it, as how long it's going. How long have they been not sleeping? If they're having increased energy, things that you look for. So what if, some questions or prompts from the guide is, what if anything is impacting your ability to sleep? Do you want to sleep but cannot fall asleep, or do not have a safe place to sleep? Have others told you that you've been acting differently than usual? Again, trying to gather that information from the person that you're interviewing. Do you hear voices from your own mind, or voices that seem to come out of nowhere, come outside of you, that other people can't hear? And then if they do respond with yes, then it's, have there been times when the voices told you to hurt or kill yourself? Looking to see if there's any types of command hallucinations, if there's something that's going on there, because that can warrant a different type of response from you. And if so, we want to look at how frequently has this happened and what happened from that. Command hallucinations are something when they're hearing that individual that we want to make sure that they haven't followed those commands before, or if so, we may need to take a different type of that orients ourselves to that level of risk. Some additional adaptations to that, or are there things you are seeing or hearing that others may not be experiencing? Have others around you told you that you have been impulsive or making risky decisions? For example, taking drugs, skipping school, spending money, gambling, and another adaptation. And all these adaptations, again, are taken from that prompt guidance. Now we're moving on to the actual safety and risk assessment portion of the tool. And what we're looking for here is we want to state that the Columbia Suicide Severity Rating Scale Screener, the CSSRS, was integrated into the crisis assessment tool itself. The CSSRS is a validated screening tool. It's evidence supported. And so when we looked at developing the tool, a portion from it, the portion of the tool that specifically assesses risk of suicide, the following tools were reviewed. The Columbia, the full assessment, the Columbia Suicide Severity Risk Assessment Screener, the one used we looked at the Firestone assessment for suicidal intent, and we also looked at the LOCUS, the level of care utilization for psychiatric and additional services. So in addition to reviewing the literature and other validated tools, county feedback was significantly integrated to ensure that this tool was appropriate for field crisis work and met the needs expressed by counties. Okay. So this is as you look at this is the CSSRS screener itself, and it's been embedded into the tool. In the screener, it has several questions and it's broken down into sections. And we're going to take a minute to go over each one of those sections and how it was incorporated and walk through the sections about it. We're also going to provide you additional prompts that can be asked as well. Again, this space itself was taken from the Columbia Suicide Severity Rating Screener itself. And so the color is for risks up front. You have low, moderate, and high, and they're indicated by the colors as yellow, orange, and red. And depending on what the individual responds to is what we're looking at. So the first section we're going to ask questions 1 or 2. And questions 1 would be, have you wished you were dead, or wished you could go to sleep and not wake up? And then the second question is, have you actually had any thoughts of killing yourself? Here, understanding that suicidal ideation is more common than we think. If people are saying this, they could potentially be at risk if they're endorsing that they've had suicidal ideation before. We ask this, we want to do it in a manner that is providing them a space to be heard. And if they do admit to having these thoughts, we don't want to jump to the conclusions that, instant hospitalization. Too often, when people or someone admits that they're having thoughts of suicide, they don't like to admit it or come forward with this information for fear of being hospitalized. And that's why the tool asks different questions if that individual is evasive. Again, there are additional prompts throughout the guide that you can ask some of these questions itself. But now we're going to go to the next 2 questions. So if they answer yes to 2, we're going to ask questions 3, 4, 5, and 6. If no to 2, you're going to go directly to question 6 in the screener. So if they do say that they've had thoughts of killing themselves, we're going to follow up with these questions. And here, what the screener is doing is it's starting to evaluate a little bit further about those types of thoughts that they're having. Each one of these can indicate a different level of risk. For example, in question 3, when it goes to, have you been thinking about how you might do this? You're starting to assess for an individual may have a potential making a plan or having some thoughts, illumination about how they would take their life. And the example that's in the screener itself is, I thought about taking an overdose, but I never made a specific plan to when, where, or how I would actually do it. And then they would go on to say, or potentially, I would never go through with it. So this question is trying to gather additional information on what that individual is going through, if they're having any types of planning, thoughts of how they go through it, and then potentially for a barrier, a buffer of what's happening with them. The 4th question takes it a step further. If the individual has potentially thought of having thoughts of how they would take their life, and they may have some sort of plan, or they are thought about potentially, I would maybe take some pills. Okay, so I'd overdose on the medication. The 4th question is asking, have you had any thoughts and had some intention of acting upon them? So here's where we're looking at if there's additional attention on acting upon those thoughts. And that's a bit different. So we want to make sure, and if they answer that, that would put them at a higher level of risk. Question 5, have you started to work out or worked out the details of how you would kill yourself? And do you intend to carry out this plan? Again, if they answer yes to this, we're asking to see if they have any information. That will put them at a higher risk for potentially to take their life. And so those would, as you mark those down, that would be indicated in that red section, placing them at the higher risk. If they answered no to all of those previous questions, as noted, question 6 here is done to help them elicit potentially that they may have some of these thoughts. Have you ever done anything or started to do anything or prepared to do anything to end your life? Example, collected pills, obtained a gun, gave away valuables, wrote a will, a suicide note. Individual took out pills but didn't swallow any, held the gun but changed their mind, or it was grabbed from their hand, like interrupted, attempt, went to the roof but didn't jump. So this is just, again, assessing for risk as we move through it. Scale again and asking from that. So for questions 1 through 6, if the person in crisis reports yes to those questions, 4, 5, 6, the individual could be at a potentially high risk. If yes to question 3 and no to 5, the individual would be at a moderate risk. This assessment can only determine the level of relative risk by death by suicide. And then we wanted to please follow the steps below. If the person in crisis is at moderate risk of suicide, continue the suicide plan assessment section below to assess the different level of means. And we want to make sure that we continue on throughout the assessment. Here is just a reminder of the mnemonic, is the path more. Because we are looking at individuals who could potentially at risk for harming themselves, we want to make sure that we're looking at these different factors. Are they having ideation of suicide? Are they using substances such as alcohol or drugs? Are they having anxiety? Are they having a sense of purposelessness? Are they feeling trapped? Are they feeling hopeless? Are they withdrawing from individuals? Are they having anger, rage, uncontrolled anger, or reckless behavior, or sudden or marked mood changes? Here's when we go into the means assessment. So this is when we're looking at if there's a specific plan for suicide and means assessment. We want to check and see if they have a plan, what's actually happening with them. So here, have they thought about when the individual would end their life? And we go into a yes, no. They thought about that, again, that could potentially decrease their safety and increase risk. And then we ask a scaling question here on a scale of 1 to 5, where 5 indicates that you intend to act on your plan to kill yourself today, and 1 indicates you have no intent. How would you rate yourself? And this is a self-rating component. You're going to take it whatever the client states for face value and rate them there. And then we're going to think about the person in crisis. Do they have the means available to them? If they have thought about how they would kill themselves, no. Do they have access to those means? And those questions listed above. And then we want to check and see if they have access to weapons or a firearm. And yes, no, as we move through it. So some questions to ask is, have you started to gather, or how you would, the means of how you do it, you would use to take your life? Do you have access to them now? Do you have methods available to take your life, such as over-the-counter pills, prescription pills, knives, or proximity to a grid subway? Have you had thoughts of how, have you had some thoughts of acting upon them? Have you thought about how you would end your life? So just some things to assess there. Another question is, you mentioned if the person talks about harming themselves or jumping off the building, and how we can mitigate that risk. Do that assessment. And then again, when there's an immediate risk, is talking about wanting to die or kill themselves, looking for a way to kill themselves, such as searching online, obtaining a gun, or obtaining those means. Talking about feeling hopeless or having no reasons to live. So for serious risk, other behaviors may also indicate a serious risk, especially if the behavior is new, has increased, or seems related to a painful event, loss, or change. Talking about feeling trapped or unbearable pain, talking about being a burden to others, increasing the use of alcohol or drugs, seeming anxious, agitated, or behaving recklessly, sleeping too little or too much, withdrawing or feeling isolated, showing rage or talking about seeking revenge, and displaying extreme mood swings. Now I'm handing the most basic things. Look for the warning signs and make an attempt to understand them. This is what you're doing during the intervention. Focus specifically and directly on suicide, and we're asking them if they're going to kill themselves or if they have a plan to die. It's been established that they have these intentions. We want to slow it down. Remember that the relationship is what heals. If they are not immediately going to harm themselves, stop, use the active listening and reflection skills to hear them. Work with that ambivalence, the choice, the thoughts of living and the thoughts for dying, and helping them stay safe for now. How can we help them stay safe for now when allowing them to explain their story and hear what's happening to them in their life, and ultimately providing them that autonomy. And then you want to work towards establishing a plan for safety, deactivate the suicide plan, promote protective factors, and then link them to resources and potentially the follow-up. Turn it over to Danielle.
Thank you, David. And I see, Brittany, you have your hand up. Did you still have a question?
Yeah, I was wondering if in the Columbia assessment, if there's a typo. I think it says 4, 5. It's either 3, 4, and 5 or 4, 5, and 6. And I think it should be or, because if they answer yes to any one of those questions, then at least I think that's the way I've seen the Columbia assessment in other versions. Can you guys clarify just to make sure that the assessment's used appropriately?
On what part, Brittany?
On the assessment that's embedded. So I think it's the Columbia risk assessment that's embedded in the crisis assessment form. I think there's a typo where it says and rather than or, when you're looking at, it's either 3, 4, and 5 or 4, 5, and 6. I can't remember the number off the top of my head.
Yeah, this was pulled directly from it, but I'll definitely go back and look and notice that just to make sure that that's correct, because it was pulled directly from the Columbia website itself, and we didn't make any alterations to it.
Okay, yeah, or maybe, I mean, at least we were trying to put the form into our EHR, and when we were conducting some testing, it didn't seem to make sense that it was and. So when we pulled up the version that exists, on the interwebs, most of the versions that we saw said or rather than and. So maybe you guys can provide some further guidance or feedback so that we can clarify that as we develop the form for our use.
Yeah, sure. Definitely, we'll send something out. But that was pulled directly from it. So we'll take a look.
Okay, thank you. I appreciate that.
Absolutely.
It's also important to note there are different versions of the Columbia screener, and this is just the full. There's a full battery, and this is just the screener. So we'll make sure that if you can double check too which one you're looking at, because we actually pulled just from the screener. So, but we will double check on it.
Thank you. Yeah, that would be helpful. We want to use the tool that you guys provided, and we want to make sure that we're catching any risk for suicidality, right? So we want to be just diligent about the way we're using it and make it appropriate. So we'll double check on both ends, and maybe we can touch base offline or something and then clarify.
Yeah, absolutely. Thank you for bringing that to our attention. And again, we'll go back to it and shoot us an email. That way we can connect, like you said. That way we can make sure we're covering the same thing. Thank you.
Thank you.
All right. The next section of the standardized tool looks at violence and homicidality risk. And so you can see here that there are a set of questions to measure or to assess for any potential risk for violence and homicidality. And so the first one is, does the person in crisis have thoughts of violence towards a specific group or person? And these are all yes or no's, except for if the person responds yes, below 1 and 2, there's this place to take essentially some notes, like who are you thinking about hurting? And so if they're identifying a specific person or place, you want to make sure you're documenting that, because this could potentially lead to a TerraSoft report, a duty to warn, and you must follow the ethical and legal standards around a TerraSoft report and the duty to warn mandate, as well as any additional protocols or procedures that your county has in place. And so the rest of the questions from 3 down. So 3 is, essentially 4 questions. So if the person is threatening to harm someone else, you're going to ask these additional questions. Is there an identity of the intended person? Do they have a method or intention to act on these threats? And if the person in crisis has access to actual lethal means, so a firearm or some sort of weapon. Now, in terms of protocols in place that, within your county, you want to make sure that you're establishing those, or that if you have them, you're following them and you're aware of them. But then the responses to here are, if yes to 3, B, and C, if no to 3B and C, if yes to 3C only. And I'm not sure what happened here. There in the actual tool itself, there's guidance on what to do. And so within whether it's safe to send out, based off the responses, whether it's safe to send out a mobile crisis team member or not, or if that's something that maybe needs to be first handled by law enforcement to ensure safety and secure the scene, and then the mobile crisis team can go out. So there's actual guidance in the tool on what to do based off the responses here. I do apologize. I'm not sure what happened with the PowerPoint. The responses are missing. And moving forward, so assessing for impulsivity is always important when we're assessing for a person in crisis and risk. Asking, and these are all questions that can be asked in a different way, and that's the purpose of the companion guide, is that the companion guide offers alternative ways to ask these questions. And so have you ever done something to put yourself or others at risk without even thinking about it or without thinking twice about it? And if they responded yes, asking a little bit more, can you tell me what happened, to try to understand the level of impulsivity and the reasoning behind it. Impulsivity is seen as a risk factor for safety, right? From a biological and neuropsychological perspective, impulsivity is characterized by this failure of being able to inhibit any potentially risky behavior or impulse for the individuals and other people around them. It's this inability to kind of have control on impulses and thoughts. Impulse control is an important component of our executive functioning, and it plays a really important role in how we function and how we make decisions and how we keep ourselves and others safe. And so considering impulsivity is really important when we're determining, safety and whether there's the higher level of risk there, because this person might be more impulsive, especially in children, they often learn to react immediately in order to achieve what they desire. So there's some differences and nuances there. And so impulsive individuals oftentimes lack the ability to evaluate the consequences of their actions in that moment, or at all, sometimes, either whether it's for themselves or others. And so we want to make sure that we're assessing for impulsivity to determine, is this person able to remain safe in the community? And like I said, there are specific considerations for children and youth as well. And so when assessing children and youth in the field when they're in crisis, it's always important to communicate in a really straightforward manner, speak at a level that is appropriate to their developmental level. Younger children have less language or are able to provide less details than older children. Discuss, what they feel comfortable talking about, just because we're asking questions and assuming that they're able to give us responses, it doesn't mean that they're comfortable, and it's okay to sit with that and address it. Important to watch for reactions as you have discussion with them. Slow down if you need to, circle back if you need to, if they look confused or upset, and listen openly. Children and youth typically will tell you what they're feeling and what their worries are. And so if we can listen with an open mind, it's really helpful. If you're responding to a school, it's really important. Some of you do respond to schools. It's important to connect with the referring party to gather collateral information. They might have some information that you're not able to get from the kiddo or from the family that is really pertinent to the crisis and resolving the crisis. And so there's a place in the tool to kind of gather that information as well. And so I'm going to pass this back to David.
Yeah, so children and youth. So as we mentioned here in that section, children and youth, we're going to try to meet them at the school, what school they're in, what grade they're in, if there's any teacher, any educational needs that may be there, and then again, check for social, emotional behavior concerns that potentially could be affecting that child. We want to be checking to see if there's any bullying or supportive services in place that can help those individuals out. And then we start to assess for, or we're looking or assessing for substance use. And here in this section, we're checking to see if the individual is currently impaired due to a substance use, and then or either through the questioning or through the observation. And if they are having this, some of the guidance that was received is can they tell me a little bit more about the drug use? How do you take them? How often do you take them? What's positive about these drugs for you? What's negative? And what have you noticed about the drug use? How has it changed over time? So making sure we're checking on that. And then some additional questions that you can ask is, how has it harmed you? Can you tell me what you've noticed about it? Things of that nature. And then we want to check to see if there's any recent hospitalizations. That's the next section of the tool that goes over. Because that also poses a potential level of risk or a connection to a hospital that they may want to return to. Have they been hospitalized in the past 30 days for a mental health care? If yes, we want to gather the date of discharge with any medications that have been issued. Have they started any medications, or has anything changed? The date of the discharge and any types of medication issued. If they have a mental health provider, we want to try to gather that information there as well, and the date of their last appointment. And then if they've had any ongoing medications, is the next section that we look for. And asking if they're taking their prescribed, are they currently prescribed any supplements or medications prescribed for you or someone else for mental health? If so, which ones? And we want to get those information there in the tool, as it could potentially help us understand what's going on with that individual. And we want to ask them if they're taking their medications as prescribed. And if yes or no, we'll mark it there. And then when was the last time you took medication? What was the dose? And did you take the medication as prescribed? Another key indicator there. Then we want to go to looking for any relevant medical history. And what illnesses or diseases have you experienced that may have been impacting your situation today? So gathering that type of information here to see what's going on that could be contributing to that crisis event. For example, is there changes in health could activate depressive issues? So we have to figure it out from there. So just gather that and ask it, as this helps us, and the tool is guided to help guests get all the information and hear that individual story as you're trying to help them in crisis. Now I'm passing it back over to Danielle.
Protective factors, strengths, and resources. Within the tool, there is a place to gather this information. Protective factors are important because they are those factors that can protect us from any potential risk factors that are present. It doesn't, just because risk factors are present doesn't, like what David said, doesn't mean we're at imminent risk. Their protective factors are unique to individuals, and it's important to allow the person in crisis to tell us what they are. We can ask prompting questions that allows for discovery and understanding of what they deem valuable to their life. These are some potential protective factors. They are not all of them, but these are some that can provide for self-regulation, interpersonal strengths, and hopes for the future. And so in the companion guide, there are additional protective factors that you can measure for and ask about. So, there's some examples here on the tool, but the companion guide really provides a more detailed list of different protective factors to ask for. And many of you are probably already doing this and used to doing this, is measuring protective factors against risk factors and going from there. And so it's important to continue this practice, as protective factors are there, like we said, to protect and provide that kind of interpersonal strengths and hope for the future. Determination of safety is next. And so determination of safety, we really worked towards making this, to align with the transformation of care as well. And so asking those questions about, is this person still at imminent risk, or were they ever at imminent risk? Yes or no? Did the individual in crisis experience relief? And were other alternative solutions found to the crisis? So, other than hospitalization and things like that. So, was there ongoing care, some linkage to further ongoing care, things like that? Are they able to remain safe in the community? And if they are they able to engage in a safety planning in a meaningful way? Safety planning may not always be appropriate, right? So we have to make sure that when we're engaging someone in a safety plan, that it's an appropriate process for them in that moment. It's important that if, to listen to your intuition, like we've said, listen to your gut. If you feel like they're responding in a manner or they're presenting in a way that makes you unsure, seek consultation. If you're out with a team, talk to your team members, reach out to a supervisor if you need to. It's okay to do that. That's what helps us guide. That's what guides us and helps us make informed decisions and really keep someone safe, or, you know, provide the further treatment if needed. If the responses are no to the questions above, then the person in crisis may not be able to maintain safety in the community and may require further treatment. So like I said, consultation is going to be able to provide you more guidance if you need it. If they respond yes to the above, then it's clear that the crisis has been resolved. You can work towards creating a safety plan if it's appropriate, and, you know, with, you know, incorporating and engaging any additional supports that are available to them. And it's also, you know, a good time to start talking about the scheduling of that follow-up check-in that is required within 72 hours of the mobile crisis encounter, and any coordination that might need to happen with any other delivery systems that they might be involved with, you know, for example, an ongoing therapist. Next is there's a section on the tool for consultation concerns and notes. So these are just places for you to have an opportunity to write, you know, additional notes if needed. Like I said, consultation is a key support for crisis teams in the field. When you're insured or need additional guidance, always seek consultation. That is a standard for all qualified team members for mobile crisis teams. So like we said earlier, a clinician can consult with a peer if that's who you're out in the field with. That's okay. Bidirectional consultation is a good thing. It's helping you as your team kind of lean on each other and grow and learn together. And then adult and safety concerns, you know, if there's any potential, if you suspect any sort of child or elderly or dependent adult abuse, this is where you can, you know, you have a space to document, and then obviously you'll need to follow any, you know, your mandate requirements and things like that. The last piece of this training is really talking about strategies for engaging collateral sources. So collaterals are those people that are there present on site, or, you know, if they're participating, you know, through phone or whatnot, they're the additional supports that are there to help the person in crisis that are affected, and they are able to either support in the guidance of the safety plan or keeping them safe in the community. And so collateral information is very helpful when you're trying to work towards providing that relief and resolution of the crisis. So, you know, when we're working with kids, we typically have parents or guardians available to us, not always, but usually, and it's important that we engage them, and we have to essentially work with them, right? And so how we do that is important and can set the tone. Collateral supports are, you know, can absolutely be effective in safety planning, right? Especially with kids. And so again, we want to make sure that we're safety planning when it's appropriate. Supporting teams, supporting collaterals when you're out in the field as well can help resolve the crisis more quickly with better outcomes, right? If we're working with kids and families and parents are part of, you know, the crisis, and working with them and being able to support them, meaning finding them additional supports and resources that they might need as parents, might help resolve the crisis and also potentially keep them out of crisis in the future. And so engaging and supporting them is just as important as the person in crisis. In summary, I'm passing this back to David. David's going to summarize this up and close us out.
Yeah, thank you, everyone. So hopefully we, you know, again, sorry for the tech issues, but yeah, so what we wanted to go over today and just provide an overview of what Crisis Assessment 1 was, talk about what the BIN guidance and what qualifies a mobile crisis team member who's been trained, and then crisis assessment, and understanding that anyone who's been trained from that mobile crisis team can complete the crisis assessment. We want to summarize the rationale behind the development of the standardized tool for crisis assessment template. We learned about the additional prompt questions provided in the companion prompt guide that can help teams gather information from diverse populations during the initial face-to-face crisis assessment. The training walked through each section of the standardized tool and explained the importance of assessing each element for risk and safety. Again, learning out how to observe those warning signs and help them understand when someone is imminently at risk for suicide, and included the guidance on how engaging others on site, collaterals during that mobile crisis encounters to support resolution of the crisis. And here's our references, and that takes us out for the day. Our references. And then I know your feedback is important to us. The post-survey attendees will need to opt into the 90-day survey so we can collect your emails and send out certificates of completion. The completion of the survey is vital to our quality control and the future funding of this project, as it allows us to provide you with training and technical assistance at no cost. In addition, it allows us to continue to improve our services and provide information and resources needed. So please take a few minutes to complete your survey or the survey. Your time and feedback are greatly appreciated and valued. And I know we're over time, so thank you so much for everything today. And general questions at mobilecrisis.info@cars-rp.org.
And I did want to let you all know that we did pull up the tool that is available. And it does look like it is missing the guidance in that specific section of the tool that we were discussing. And so we will address that immediately and get a revised version out so that you have the correct tool. And so we will be working on that today. All right. Well, thank you all so much for being here today. I hope you all have a great day.